Hi, everyone. Thanks for taking the time to be here today. The title of my talk is Using Multivariate Approaches in Patients with Treatment-Resistant Schizophrenia, a Multimodal Neuroimaging Study. I'd like to begin by quickly introducing the concept of treatment resistance in schizophrenia. In schizophrenia, the primary pharmacological treatment is antipsychotic medication, and treatment-resistant schizophrenia, also known as TRS, refers to patients for whom the right treatment has yet to be identified. More specifically, the classification is most often used when individuals with positive symptoms do not respond to antipsychotics. This phenomenon exists in roughly 20 to 40% of patients with schizophrenia, and expectedly such circumstances have a pretty dramatic impact at the personal, familial, and societal level. So in the current work, we adopted a study objective to use multimodal neuroimaging to identify data-driven patterns within a sample composed of patients with TRS, patients who responded to treatment, that's treatment non-resistant schizophrenia, TNRS, and healthy controls, and assess the correspondence of these patterns with group classification and symptom profiles. Our multimodal acquisitions were composed of proton magnetic resonance spectroscopy in the anterior cingulate cortex, which included measures such as glutamate and myo-inositol, structural T1 weighted images, which permitted the analysis of structure volumes like the stratum, thalamus, and hippocampus, as well as lobe-wise mean cortical thickness, and finally, diffusion tensor imaging, for which we focused on tract-based fractional anisotropy. I won't spend too much time on the preprocessing and analysis tools, but I have included them here for reference, and I'd be happy to discuss them offline as well. To address our research question, we used a technique called non-negative matrix factorization, also known as NMF. An application of NMF to an input matrix with dimensions features by subjects, of which we had 65, results in a component matrix of features by K, describing K phenotypic patterns, and a weight matrix of K by subjects, describing how each subject loads into each component. In the current work, K was set to 3. Looking at the output of NMF, here we see the component matrix, and component 1 was composed of FA measures, component 2 was composed of MRS and structure volume measures, and component 3 was composed of cortical thickness measures. The other output from our NMF analysis is the weight matrix, which describes how each subject, here represented by columns, loads into each component. The uppermost row here is only used for descriptive purposes and corresponds to each participant's group classification, so TRS, TNRS, or healthy controls. Now looking at these output matrices together, we see that the weight matrix on the right-hand side reveals a cluster composed mostly of healthy controls. That's a gold cluster with mostly orange in the first row. And this cluster is characterized by high FA, high CT, low MRS measures, and low structure volumes. In addition, we have 3 mainly patient clusters composed of both TNRS and TRS patients, and these were differentiated by the healthy control clusters by low CT, as seen in the pink cluster furthest to the left, low FA and high MRS measures and structure volumes, as seen in the teal cluster, and a combination of these 2 patterns, as seen in the purple cluster furthest to the right. So next, to relate the identified NMF-generated subject weights to behavioral measures, we use partial least squares analysis, which is a multivariate technique that relates 2 sets of variables to each other. Here we are looking at latent variable 1, which was significant, and we see that a brain feature expression of low FA, elevated neurometabolite levels, high structure volumes, and cortical thinning is related to cognitive impairment as assessed by the R-bands, exit, and JART, decreased functioning as assessed by the GAF, and a greater degree of cigarette smoking as assessed by the Brinkman Index. We can then take this one step further by looking at the PLS-derived brain scores by group, as seen on the left, where we see that there is a continuum-like increase as we go from the healthy control group to the TNRS group to the TRS group. And this idea is further substantiated by the graph on the right, which shows the relationship between the brain and behavior score with points colored by their study group classification. Ultimately, using NMF, we were able to identify data-driven patterns within multimodal neuroimaging data. On average, the TRS group has a greater expression of the identified pattern of disrupted anatomical and chemical brain features, which corresponds to the greater cognitive impairment and decreased functional capacity observed in this patient population. However, within both patient subgroups, there is marked heterogeneity at the individual level. Finally, the work presented today would not be possible without the following individuals. Thank you very much for your time today.